A very good afternoon to everyone. With so many new equipments, new gadgets coming up at every meeting, every conference, preoperative examination is gaining more and more importance than it has ever done before in cataract surgery. And now with cataract surgery becoming more of a cataract and refractive surgery, all of these things need to be incorporated as time goes on. However, the basics of preoperatives that should not be forgotten is that we need to formulate a strategy before we talk to the patient. We need to have a game plan in deciding a preoperative case. This means that we need to spend dedicated time to preoperative patients. A thing that we find very useful at our practice is that we have a dedicated preoperative slot where patients selected for cataract surgery will be coming for their eye measurements, and we will be spending 2 to 3 hours with them to decide and decode their eyes. It requires a dedicated team of optometrists, technicians, and trained counselors. This is one rule of preoperative examination which should never be forgotten. That is to do a comprehensive examination of both eyes together at the first sitting. Doesn't matter if he has a unilateral cataract, doesn't matter if you feel you are not going to operate his other eye for another 6 months. Always take bilateral measurements which will help you in planning the strategy for both eyes in the future. So all measurements need to be done for both eyes. And this is one thing that we find very useful, is to have a fixed pro forma for a workup. I know this sounds a little silly, sounds like a first-year residence job, but believe me that this works very well. So have a written and fixed set of things that you need, set of measurements that you want to do, and set of things that you need to look for in each eye so that you don't miss out on any single parameter for any single patient. Now we have various companies coming up with various high-end gadgets, and we are all confused as to which equipments should we actually be having, or do we need to have any of them. I'll be discussing some of the useful things that we find in our practice. Before making sure that we do any of these fancy gadgets tests, it is very important to look for the ocular surface. Make sure that the tear film is good and healthy. Look for the lid anomalies of ocular surface disorders like meibomian glands dysfunction or a poor conjunctival health. Gadgets like meibography may help in diagnosing the health of the meibomian glands. Coming to aberrometry. The aberrometry, what it does is measures the total eye aberrations. It helps us to localize where these aberrations are coming from, and it helps us to give an objective assessment which we can use to counsel the patients. Take for example this eye trace measurement for this preoperative cataract patient. The eye trace does the ray tracing aberrometry, which gives us a measurement of the total eye aberrations. It also, using the corneal aberration profile using the Placido method, gives us a measurement of the corneal aberrations. Therefore, now we have the total eye aberrations and the corneal aberrations individually. And subtracting one from the other gives us an indication of the internal aberrations, which are mainly contributed by the cataractous lens. Further, it also gives us a good Placido-based topography, which will help us in diagnosing the corneal aberrations, as well as in deciding and looking at the keratometric values. Another very important thing that it gives is the pupil size. Now, this is very important in selecting different kinds of IOLs. A larger mesopic pupil may require a certain kind of an IOL, whereas a small myotic pupil which does not dilate even beyond 3 millimeters in a mesopic conditions may or may not benefit with a particular IOL. Also, it gives us an objective assessment of the point spread function of the eye. So let's put it into practical case scenarios. This is a case of a Brunison grade 3 to 4 plus cataract. The only problem is that the patient has Fuchs and endothelial guttata. So having learned all the techniques from all the seniors as to how to protect the corneal endothelium during the surgery, we went ahead with an uneventful cataract surgery with an aspheric IOL in the bag and a quiet eye post-operatively. However, the patient keeps coming back to us every 15 days and he keeps telling us that, I can see well, but it's not great. And I can't see well the details, particularly in certain light conditions. This was the appearance of the patient on the first post-operative day, and we were quite happy to see this state of the cornea in a Fuchs case on the first day. So on further trying to decode the complaints of the patient, what we found is that the patient had severe amount of internal as well as entire eye and corneal aberrations. So this is what we found, that the patient had a 6/6 vision, but not happy with his vision. And the eye trace aberrometry helped us to identify the cause for this. Looking into the literature, what we realized is that these guttetas are the ones which are scattering the light from the posterior corneal surface, leading to these internal aberrations. And this is giving the poor quality of the vision that the patient is suffering from. So the corneal endothelium in this case was responsible for the glare and blurring, which in aberrometry terms mainly gives rise to internal higher order aberrations. So we realized that in such patients where we diagnose preoperative weaker endotheliums, it helps us in counseling the patients preoperatively regarding their visual prognosis. And possibly we'll keep an eye whether we would want to counsel them for multifocal IOLs. This is another standard case scenario, a 52-year-old male planning for cataract surgery. And on doing the eye measurements, we found that he had a significant amount of cylinder. And as soon as I talked about toric IOL to the patient, he shot back at me that, "Doctor, are you crazy? I've never worn glasses all my life. Nobody has ever told me that I have cylindrical glasses. And you are telling me I need a toric IOL?" So this is where the eye trace again helped us to counsel the patient. We could show to him that the internal aberrations are manifesting and neutralizing the corneal astigmatism. So the corneal astigmatism is being neutralized almost completely by the lenticular astigmatism, and therefore he doesn't have a significant astigmatism currently. Now if we were to correct this patient with a regular monofocal IOL, this internal astigmatism compensation will be lost and the patient will manifest with a significant cylinder post-operatively and an unhappy vision for distance and near. So the eye trace helped us to find out the cause and explain to the patient and counsel the patient regarding the cause for the toric IOL need. So it was an objective explanation which could be used to counsel the patient. So the patient got convinced, we did a toric IOL, and this is the post-operative picture where the corneal astigmatism is almost being completely neutralized by the internal astigmatism produced by the toric IOL, cancelling the corneal astigmatism. So again, here the eye trace helped us in understanding the internal compensation of the eye, helped us most importantly to counsel the patient accordingly, and that allowed us a good and a happy post-operative outcome. Now optics is something which I struggle to understand, and these are some of the things that I've recently discovered the hard way. The angle alpha and the cataract surgeon. We've all been learned in our residency training regarding the angle kappa, the visual axis, the optical axis, etc. So let's go through it in a little bit of a detail. The blue cross here is the center of the limbus, the yellow is the center of the pupil, and the red is the visual axis. Normally, in most cases, all three of them coincide significantly, and therefore putting any IOL would mean that the visual axis and the optical axis would be practically the same. Now, if the angle alpha, that is the difference between the center of the limbus and the visual axis, is more than a certain amount, that is more than about 0.5 millimeters, it would mean that the visual axis and the center of the eye, that is the centration of the IOL, will be quite different. In this case, if we were to place a multifocal IOL, the multifocal IOL will center in the capsular bag, that is, it will center to the limbus. And if the angle alpha is large, as in this case, what will happen is that the visual axis will pass through the rings of the multifocal IOLs. This will lead to multiple edge and glare effects and an unhappy post-operative outcome in spite of having a Snellen's acuity of 6.6 and N6. So in our practice, what we found is that in patients having a preoperative angle alpha of more than 0.4 millimeters, that's a red flag for us. And we look into all other different parameters before even thinking about counseling them for multifocal IOLs. What is most important again is to look for the posterior segment, particularly when we are considering premium IOL surgeries. Not only are the disc and macula important, but it is also very important to have a look at the periphery of the retina in doubtful cases, and never hesitate to involve your retinal colleague in the management. Retinal OCT is something that is now we find mandatory in all our preoperative patients. For example, this looks a very healthy retina on 90D and the center of the macula is fine. But just paracentral to the macula, we discovered a PED. So this patient is likely to have a higher risk of progressing into the center. Certain cases of ERM and early lamellar macular holes are easy to miss on a 90D with an advanced cataract type of IOL. Going to the corneal investigations, Placido-based topography has helped us over the years in ruling out irregular types of astigmatism and the magnitude of astigmatism. However, it doesn't give us any information regarding the posterior cornea. Newer imaging devices like the Shail and others help in a live capturing of the cornea of the anterior and posterior surface all through. So they give us measurements of the anterior as well as the posterior corneal curvature. Take this clinical scenario of a regular topography-based procedure. However, if you look at the Shail imaging, there is a significant elevation posteriorly. This may be suggestive of a form-fruste keratoconus, and this may not be an ideal case for selection of a particular kind of IOL. Therefore, in selective and certainly in special cases, these newer topographic devices are also quite helpful. In the end, what have we learned? Are these newer diagnostics really important? I think in the changing times where we are all looking to raise the bar of our cataract surgery, of our outcomes from just being clear corneas on day one or 6 Snellen's acuity to a perfect and happy vision post-operatively, these newer diagnostic devices definitely do have a role. They help in improving the predictability and probably the precision of what we want to do and how we want to do. And I think there's still a long way to go, but this is surely the way ahead.